Morning, Kristen. Can you hear me okay?
Yes, I can hear you fine.
Great. And there's a court reporter today.
Maggie.
Morning, Maggie. How are you?
Good morning, Chair Foster.
Hey. Good morning, Miss Noonan. I see you here. How are you?
Good morning, I'm well.
Great. How many people do you have testifying today?
I believe we have about 5 or 6.
Okay, great. So before we go on the record, I'll call the meeting to order, and then I'll have counsel swear you and those testifying in. Just have everyone introduce themselves, and as a group, you can affirm to the oath. And then after counsel swears you in, you can just take it away and do your presentation.
Sounds good.
Okay. And we've been allotting about 45 minutes for the hospital presentations. Is that sufficient, or would you like a little bit more?
No, that should be sufficient.
Okay, if you go a little over, it's great. Okay, it looks like everyone's here. I'll call to order the Green Mountain Care Board's hearing of August 30th, the last day of hospital budget hearings. Maggie, we can go on the record.
You're on the record, Your Honor.
Right. Good morning. I'll call to order the Green Mountain Care Board's hearing August 30th. This morning, we have a presentation from CVMC, and I see Ms. Noonan and her team here. And I'll ask counsel to swear in the witnesses, and then we'll turn it over to Ms. Noonan and her team.
Hi, good morning. This is Michael Barber, General Counsel for the board. So if you could please all raise your right hands. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
I do.
Okay, thank you.
We ready to begin?
Yes, please. Thank you.
All right, great. Well, good morning, Chair Foster and members of the Green Mountain Care Board. My name is Anna Tempesta Noonan. I'm a nurse, and I've been in healthcare for 43 years. The last 29 years have been in senior executive roles, including 7 years as the president of CVMC. We appreciate the opportunity to tell you about CVMC and the increases we need to continue delivering the high-quality care to our community. Central Vermont Medical Center provides health care for 66,000 people who live in the communities we serve. We employ approximately 1,700 people, including 275 physicians and APPs. We have a full range of acute care services and a large footprint of ambulatory sites, including 8 primary care and 18 specialty practices, an express care, and 7 outpatient rehab locations. CVMC is committed to continuously improving the efficiency and effectiveness of the services we provide. We use lean methodology and other performance improvement tools to achieve that goal. We will be sharing a few specific examples of those efforts during our presentation today. For Community Hospital, we have a broad range of services enabling our patients to stay close to home when receiving care. Part of our healthcare continuum is Woodridge Rehabilitation and Nursing. Services there include short-term rehab, physical, occupational, and speech therapies, memory, and long-term care. For our residents, Woodridge is their home. We have a resident-centered care philosophy and a resident council that meets monthly, giving feedback on programming, what we do well, and where we can improve. We know that Vermont has an aging demographic. We also know that we don't have enough post-acute beds in our state for those who need this level of care now or in the future. Woodridge is a critical service for Central Vermont's aging population, and it's critical to our care continuum. Approximately 80% of Woodridge admissions come from Central Vermont Hospital. 10% come from UVMMC, and the remainder are from other sources. Even with Woodridge in our continuum, we often have patients in our acute care beds awaiting placement to the next level of care. This bottleneck impacts patient flow through our system. A statewide effort will be required to address the need for post-acute services in Vermont. On Wednesday, we received notification from the Joint Commission that we achieved primary stroke certification. Why is that important? Primary stroke certification demonstrates that we provide high-quality stroke care, which reduces mortality and improves patient outcomes. Our geographic location, which is central, positions us to support critical access hospitals in caring for these patients, again, keeping patients closer to home. CVMC's primary stroke certification and UVMMC's comprehensive stroke center leverages a collaborative approach to caring for this population. The recent Act 167 study validated what we're already experiencing at CVMC. We are caring for an aging demographic. The study indicated that over the next 20 years, our health service area will continue to experience an aging population that will shrink by approximately 9%. This demographic shift is projected to reduce our potential workforce by 28%. Medicare eligible patients will increase and likely result in higher incidence of stroke, heart disease, and cancer-related hospitalizations. These conditions cost more to treat. Today, our med-surg unit primarily treats complex medical patients. We have very few inpatient surgical admissions as we shifted most of our surgical volumes to our ambulatory setting. In 2018, we launched innovative workforce programs in collaboration with the Community College of Vermont and Vermont Technical College. The first track was for licensed practical nurses. We later added an RN track, LNAs, phlebotomists, and other technical programs. Our first round of graduates completed their programs in 2021. From 21 to 24, the investment in these programs has been approximately $3.8 million, with an estimated cost avoidance of $4.5 million in traveler costs. We've seen a 65% retention rate across these programs. These earn while you learn strategies enable our staff to advance their careers and earning potential, all while working here at CVMC. 60% of those who graduated and completed the first program were also the first in their families to engage in post-secondary education. So this is a generational game changer for those families as well. In June, we graduated 10 more students, 6 LPNs and 6 RNs. For our RN graduates, 1 started as an inventory specialist at CVMC, 2 started as transport aides, and 3 started in our LNA program. All 6 completed our LPN program, increasing their earning potential before completing their RN degrees. Again, these earn while you learn programs are critical to retention of our most important resource, our people. All these programs and others are now part of our network's Center for Workforce Development. It goes without saying that access to healthcare is critical to optimizing patient outcomes. Our efforts to expand access is a driver of our variance from the board's NPR guidance. Partnering with our network colleagues, we've been able to improve and move appropriate surgical cases to CVMC, and that work will continue in 2025. This effort has a positive impact on wait times. By shifting these volumes, we also open up time at UVMMC for the tertiary and quaternary surgery only they can provide. An additional benefit of our network is sharing providers and joint recruitments. We currently have 11 surgeons who operate at both CVMC and UVMMC. An additional 4 are in the process of gaining privileges to our hospital. To improve access to endoscopy services, we've invested in staff and related equipment to operationalize a 3rd endo room. I'd like to now introduce Dr. Fama, who will be sharing efforts to improve access in the ambulatory space. Teresa?
Thanks, Anna. Good morning. My name is Teresa Fama, and I'm a rheumatologist at CVMC. CVMC supported me in starting a rheumatology practice at almost 18 years ago after completing my training at UVMMC. Throughout my tenure, I've seen access to specialty care become more challenging problem, causing frustration for patients, primary care physicians, and APPs and specialists. Today, I'm going to focus on specialty care initiatives. This slide shows the primary care, the slide before this slide showed the primary care and specialty care initiatives across the UVM Health Network. The primary care initiatives are the same across UVM Health Network and were discussed at the UVMMC hearing 2 days ago. Therefore, I will not spend time discussing the primary care initiatives again, and we can discuss more in the Q&A should the board have any questions. So moving on to the next slide. Speaking for CVMC Rheumatology, we are a regional hub for rheumatology care. We see patients from all over the state: Newport, St. Jay, Randolph, Bennington, and now that Dartmouth-Hitchcock Rheumatology has limited their acceptance of new patients, we're seeing an uptick in referrals from New Hampshire and our Northeast Kingdom. So when we think about our specialists at CVMC, we're not just serving patients in the Barry-Montpelier area. We're serving patients in the greater region. Having a modern health record allows us to use digital tools to perform actions we couldn't do with paper charts. These tools, namely e-consults and enhanced referrals, as well as an initiative we launched last year to refer patients back to their PCP when specialty care is no longer needed, provide us with ways to address the demand side of the equation regarding access to specialty care, and tries to address the patient's problem at the right time and in the right setting, thus eliminating waste and reducing the total cost of care. This slide demonstrates that we're moving the needle in the right direction. So let's talk about e-consults. CVMC clinicians generated about 1/4 of the e-consults of the UVM Health Network, and this number has tripled when comparing fiscal year 23 to 24 year to date. E-consults have allowed a vast improvement in getting answers and assistance to PCPs and other clinicians with a turnaround time of less than a week. And for rheumatology and some of the other specialties, we answer the e-consult in less than a day on average. Moreover, we've demonstrated that e-consults avoid a clinical appointment 9 out of 10 times. For enhanced referrals, these help to improve the appropriateness of the specialty visit. They also help to triage referrals to identify urgent visits, and they guide testing to increase the efficiency of the first visit and may reduce the need for a follow-up visit. At CVMC Rheumatology, we've seen our wait times cut in half this past year, and that's holding constant the supply of our rheumatologists. For refer back, CVMC specialists have referred back to PCPs 70% of the referred back patient volume to date. This translates into opening up about 800 slots for new patients and for follow-ups. And PCPs, both internal and external to our network, have welcomed this initiative. From my personal experience over the past 2 years, this work has led to an increase in collaboration with my primary care colleagues across the network, not just at CVMC, and an improvement in the ease of collaboration. I know PCPs and all the way out to Alice Hyde across our network and have gotten to know them pretty well. Identifying patients who need to be seen urgently and getting these patients in. We have dedicated slots to get these patients in. Shorter wait times at CVMC, pleasing patients and PCPs tremendously. Higher quality new patient consults, helping to reduce physician burnout. Hearing from our trainees that their experience is more relevant to their specialty training, increasing their satisfaction in their fellowship, and thus increasing the odds of them wanting to stay in Vermont and potentially bolstering the attractiveness of trainee programs. And then I just want to make 2 final points. First, as we adopt digital tools for both primary and specialty care with the primary goal of improving access to care, how we historically have measured productivity, that is using the work RVU, is outdated. Patients are expecting access to care in ways that don't entail a traditional office visit. And yet we continue to measure productivity based on synchronous, in-person, and more recently, telehealth interactions with patients. We're doing several asynchronous activities involving patient access that is not measured in the work RVU. With e-consults and enhanced referrals, it often takes longer to complete the order for these referrals because they require more data input up front by the PCP. And with e-consults, often the PCP follows up with the patient on the result of the e-consult via a phone call or a MyChart message, both of which do not generate work RVUs. Another important example is MyChart or portal messages from patients. Last year, our CVMC PCPs received just over 78,000 MyChart messages, an increase of 270% compared with 2020, the first full year of Epic implementation at CVMC outpatient setting, and about 8% increase from 2022. We respond to these messages outside of our clinical time, often during our lunchtime and after hours, or what we call our pajama time. Often these messages take the place of a visit. For example, 2 days ago, of the 10 messages in my Epic in basket within the first few hours of the day, half were MyChart messages from patients with issues ranging from, quote, my hip is hurting and I think I should do physical therapy again, to, quote, my pharmacist listed out all of the vaccines I should get this fall. Can you tell me, given that I'm immunocompromised, which ones I should get and when? To photos of bruising on a leg of one of my patients and asking what I thought about it. Clearly, these examples could be office visits, and yet they were addressed by me on administrative and not clinical time. My colleague, Dr. Sandoval, who you heard from the other day, she makes an analogy to what we are experiencing in medicine to that of measuring a bank's productivity only by the number of customers who visited the bank in person to do a transaction, such as withdraw, deposit money, apply for a loan, etc., as we did in the past. If measured this way, then banking productivity would have significantly decreased because it wouldn't consider access to ATMs, online banking, direct deposit, and applications such as Venmo. It's time to think about productivity in a much broader, enlightened, and modern context, reflecting the care we're providing today and not 5 to 10 years ago. We are not alone. Organizations across the country are working on ways to credit clinicians for all of the clinical work that occurs outside of a historic in-person visit. Finally, I want to say that I was asked to speak to this hearing last year and I declined. I accepted this year because I've witnessed firsthand the collaboration, the support, the resources, and perhaps most important, the curiosity of our new network administration to work with my primary care and specialty colleagues to see how we may apply ideas and innovative concepts to improve the experience of our patients, our physicians, APPs, and staff. Thank you for listening.
Thanks, Dr. Fama, for sharing those insights. Shifting back to the acute care setting, again, in an effort to improve access and promote care delivery closer to home, CVMC has enhanced our critical care services. We're becoming a growing referral site for the region's critical access hospitals. Fiscal year to date, we've accepted 48 transfers into our ICU from outlying hospitals. CVMC is also expanding our certified nurse midwife program to support 24/7 coverage in response to community need. Together with our network partners, we're embarking on a multi-year strategy to upgrade linear accelerators across our system. One of these is located at CVMC. These machines will allow for more efficient and precise treatments, potentially reducing treatment times and providing high-quality imaging during those treatments. The CON for this upgrade was submitted 6 weeks ago and is in the review process. In orthopedics, we recently acquired a Mako system, which allows our orthopedic surgeons to create customized surgical plans based on each patient's unique anatomy. As our population ages and the demand for total joint replacement increases, We're committed to staying at the forefront of technology. Advancing the health of our population requires a whole system approach. CVMC serves as the convener and now fiscal agent for Thrive, our accountable community for health. Thrive is a community collaborative that promotes the integration of health and social services. Leadership partners include Washington County Mental Health, Central Vermont Hospice and Home Health, Green Mountain United Way, the Department of Health, and many other not-for-profit organizations and agencies. Thrive leverages the expertise, resources, and data to address gaps in the social determinants of health. Thrive leadership partners have supported our last two community health needs assessment and the development of our community health improvement plans, which for many of those organizations become their improvement plans. A few examples of the outcomes of this partnership include a collaboration with Community Rides Vermont, launching an on-demand transportation service to facilitate medical appointment visits, hospital discharges, and pharmacy visits. Our Central Vermont Prevention Coalition promotes innovative, community-wide approaches to addressing substance use. We were recently awarded a 5-year grant to focus on reducing substance use in our youth using a family system lens. Thrive also secured a grant from the CDC that focused on understanding health equities in our post-pandemic environment. All of these community initiatives and others are focusing on improving the health of the population we serve. Throughout this presentation, we've highlighted the value of system integration. On Wednesday, we talked about the administrative efficiencies gained by shared services and the value of a network-wide approach to maintaining contract labor and managing that labor. Seamless sharing of patient data is critical to optimizing the care we deliver. As Dr. Fama has already mentioned, CVMC now has Epic as a platform. As a community hospital, we would not have been able to implement Epic if we weren't part of the UVM Health Network. With Epic, care delivery integration is advanced, and we now have better access to data that enables us to reduce variation and advance clinical outcomes. So with that, I'm going to pivot and introduce Kim Patno, our Chief Financial Officer. Kim?
Good morning, and thank you for inviting me to speak. My name is Kim Patno. I am the Chief Financial Officer for Central Vermont Medical Center. I have been in the healthcare system for over 36 years, of which 14 I have spent time in another state. Hence, I may have a little bit of an odd accent to y'all. In the great state of Louisiana, learning and experiencing healthcare outside of the state of Vermont. 4 years ago, however, I felt a calling to come back to the state of Vermont and to help contribute and move forward our healthcare systems and financial opportunities. On slide 18, as the next few slides we progress, we do know, as per the guidelines of the Green Mountain Care Board, the net patient revenue increase is over the guidelines as discussed. I first want to talk about what is causing some of the variances in the fiscal year 2024 performance compared to what our budgeted net patient revenues are. We do have several one-time enhancement payments that are not going to be repeated in the 2025 fiscal year. One is that being the employee retention credit that we have booked for the calendar year 2022, and that is reported in other revenues for $1.9 million. We also, as part of CVMC, Woodridge, our rehab and nursing home facility, we applied and received extraordinary financial relief funds last year based on the state fiscal year, which runs July to June, for $1.3 million. Those numbers are reflected in our net patient revenues for this fiscal year. We have applied, have not received yet for a continuation of this for Woodridge in the 2025 year, but is in our budget. We're hoping that we will be receiving that monies because it is very important to keep that money flowing to help cover the costs of our nursing homes. In fiscal year 24 and is in the base budget, we've seen improvements in our volumes. Those are most notably noted in the MRI, CT, I typically will refer those to the imaging services, lab, our medical group, our physicians are seeing more patients, and pharmaceuticals insofar as related to our outpatient infusion and chemotherapy. In these revenues, they go hand in hand with increases in expenses. We've seen an increase in our staff salaries and supplies to commiserate with those volumes. Fiscal year 25 does include the fiscal year 24 actual volumes as part of our base budget. We do review our budgets and increase our volumes for additional access to improve our and wait times. As noted in Anna's presentation, GI and endoscopic services, for example, are an enhancement and an increase in volumes for this fiscal year. Net patient revenues. CVMC continues to focus on reducing payer denials in the areas of pre-authorization, provider enrollment, and timely filing. In our other revenue section for 2025, excuse me, we continue to work and maintain with our UVM Health Network to improve our 340B revenues to assist our patients with affordable access to their medications. This continues to be a challenge with continued pressures and demands from our manufacturers. Expenses in the 25 fiscal year will be tied to volumes, primarily again in the salaries and wages and benefits and supplies. Salary, wage, and benefits are tied to market demands, and CVBMC continues to remain competitive in that area. Other expenses do include costs to provider taxes as a result of increased net patient revenues for about $760,000. In the previous two slides, we talked about actual to performance to budget and actual performance to build the 2025 budget. This slide actually refers back to a budget to budget crosswalk. CVMC has experienced minimal changes between payer mixes, but where the material changes are focused is on volume improvements, and you see that in column D. When CVMC builds our budget, we review the previous 12-month trendings for volumes. We add and or subtract known volume changes that will impact us. For example, physician retirements, physician recruitments that have signed and are part of the CVMC family coming forward. We also look at technology changes to improve access. Dr. Fama mentioned some of those access changes, even though they may not improve revenues, they are improving access to care. The 11.9% increase comparing budget to budget, 8.4% of that is already built in our current fiscal year run rate. We are adding an additional 3.5% increase to our net patient revenue for volumes from the work that we're doing to improve access to our Vermonters across the state of Vermont, as well as in central Vermont. As noted in the previous slide, volumes are stronger than fiscal year 24 budget. And this slide identifies the largest impacted services. The volumes are in the fiscal year 24 projection and the base budget, as noted on the right side of this screen. The $23 million increase in net patient revenue from the previous slide does come at an additional cost in labor and supplies. This slide is the mathematical crosswalk of the increased costs of $9.6 million. We do adjust net patient revenues for any addition, as I noted, for any additional changes in other revenues, which is shown in the middle of this page, and that's really related to the 340B revenues or our contract revenues. To the right is the detailed breakdown of what the inflation costs will cover. You will note, again, the highest cost will be our labor, salary, wages, as the majority of these costs. All other inflation factors, with the exception of pharmaceuticals, we average about 3% increase. The commercial rate increase is also in our requirement to respond to being over the 3.4% guideline. This slide breaks down the cost inflation of how we crosswalk the commercial rates that increase needs to serve our community. One of the first steps we look at when we are going to do a crosswalk is focus on increased efficiencies and to reduce the pressure on commercial rate increases. We recognize commercial rate increases cannot be the end all be all to cover all these costs. We continue to work on initiatives to maintain and reduce length of stay for our patients. We look at our utilization review and utilization management of those patients. And we also are reviewing with our network colleagues through our PHSO work as noted in Wednesday's UVMMC's presentation to continue to work with our commercial payers for quality measures and reimbursements. At the time the budget is built, we also adjust government commercial rates known for governmental changes in reimbursements. To the very far right of this calculation, you will note that every 1% of our commercial rate increase equals about $960,000. Before we leave the slide, I do want to point out as a reminder that Judy, my colleague from UVM Health Network, noted just because we calculate a commercial rate increase, we do have additional dollars that do not equate to the actual $960,000 we estimate. We would be remiss to remind ourselves that the $960,000 does come with perhaps an increase in bad debt and or charity, as well as an increase to our provider tax. So to summarize, the $960,000 after estimating the provider tax and bad debt is actually around $856,000 as noted at the bottom half of this slide. To tie cost inflation to the requested rate increase, this slide summarizes the previous mathematical crosswalk to the one table. On the left side, we summarize the net cost inflations of the $9.9 million less the known governmental increases and initiatives to summarize the total commercial rate request of $6.3 million. As a reminder again, the table to the right, it has the spread of what the cost inflation is, and again, focuses in on salary, wage, and benefits and pharmaceuticals being the highest drivers in addition to volumes increases. I would be remiss if I did not look at several of the studies that the Green Mountain Care Board staff presented. This graph is a summary of the Bartholomew and Nash report that highlighted CVMC in the highest quadrant of price per patient and cost per patient in the upper right quadrant. We have reviewed the data and the calculations and discovered this report is incomplete in its assessment insofar as it has inadvertently included our nursing home for Woodridge Rehab and Nursing Facility. And on the following slide, you can follow the math calculations when we remove the Woodridge Rehab and Nursing Facilities out of the cost report data that was used. It actually moves our price per patient cost from 175% to 137%, and our cost from 126% to 108%. So if we go back to the previous slide and we follow our little blue square, which is where CVMC was originally marked at, to the little house or triangular shape with following the arrow, it actually brings our price and our cost more in line with our colleagues across the state of Vermont. We know we are not done, and we continue to work toward reducing costs to our Central Vermont community. But as you can see, once this calculation was made, CVMC is compared to our hospitals and is no longer that lone outlier. On this last slide, we would also like to look at the NASP 2023 data because it does give one pause when Central Vermont became looking so high in compared to benchmarks. The peer groups that we have used in this analysis are the same that the Green Mountain Care Board staff shared earlier this month to you. When we reviewed the data, we discovered that the data was incomplete. And again, Woodridge Nursing Home has been captured into some of the data and not completely all of the data. And column A, where the administrative salaries are pulled from, Woodridge's administrative costs are captured in column A. The clinical salaries would not be captured until we pulled out below the line and we add in column C $10 million. We need to adjust the clinical salaries, column B and C together to come to an adjusted clinical salary. We also would be remiss when we look at column A by itself does not include all of the costs for administrative and general because a cost report is at best a tax return, but is not complete with one column. So we combine the two financial we combine additional columns in the worksheet from the cost report, and we added our home office costs, which are added in column F, as well as the administrative columns from other hospital facilities. Column H is now a revised administrative to clinical cost ratio in blue, and CVMC is calculated at 27%. Based on the NASB report, it was 18.7% originally. When we realigned and looked at the hospital that has zero administrative costs, if we find that hard to believe, we did eliminate that particular line and adjusted that out of the peer group. And actually CVMC is now at the median of the peer group. To close, CVMC is requesting that the Green Mountain Care Board approve our budget as submitted to maintain the high quality of services for the communities that we serve. We recognize the net patient revenue is 11% above the 2024 budget. And we also recognize we're asking the commercial rate increase of 6.4%, which is also above the Green Mountain Care Board guideline. We believe these asks are reasonable and are much needed to continue to remain competitive in our wage and salary components, as well as care for our patients. Thank you, Chair Foster. I turn it back over to you.
Thank you. Sorry, I was having a problem with the mute button. Thank you for the presentation, and I'll turn it open to the board members for questions.
I can go ahead and jump in. This is Tom. Thank you for the presentation. I appreciated Dr. Fama's comments on the need to modernize our measures of productivity and efficiency. I think it's important that regulators, policymakers, and providers, as well as administrators, remain both committed to evidence, but adaptable at the same time. So I appreciate the analogy that she used. I also appreciate the shared commitment that you described in your narrative to timely, high quality care that's quote unquote equitable, both fiscally, physically and financially. In your community needs assessment, you identified risk behaviors contributing to chronic conditions, mental health care and care for patients struggling with substance use disorders, and challenges associated with housing, transportation, childcare scarcity. I'm wondering, what does equitable financially mean to you all in regards of those community needs?
Oh, I'll speak to that, Member Walsh. I think that probably that term means different things to different people. For us, what we're trying to do is make sure that we're trying to provide the best care we can and care that's affordable. So all the work we're doing here at CVMC and the work that I spoke to, the work that Dr. Fama spoke to, are all efforts to try to optimize the efficiency of our system so that we can manage the costs that we're sharing with our community.
Is there a, I understand your perspective that it means different things to different people. Do you have a source or a reference, a subject matter expert that you rely on for your definition of equitable?
We do not have a source. We have financial policies that call out different income levels that then we adjust based on that. We also, as a non-for-profit organization, obviously provide a significant charity care to our community based on their ability to pay. So working with our advocates in the state, we've worked with them to develop those policies, clarify those policies so they're easily understood and consistent, not only across our network, but across the system in the state of Vermont.
Okay. Thank you for sharing your view. I think it's important that as regulators, we need to understand how you define and assess terms like equity. I want to turn for a moment to your balance sheet and just make sure that I'm looking at the right one with you all. Your assets grew from 61 million in 2020 to 67 million in 2024, and long-term debt declined from 19.7 million to 5.8 million during that time. That's an impressive decline. And the largest change in long-term debt occurred between 2021 and 2022, when it fell from 15.4 million to 11.7 million. How did you accomplish that?
Member Walsh, would you mind having that slide pulled up so that we can look at it together, please?
It was the documentation that you all submitted to us, your balance sheet.
I do not have that in front of me, so I would really ask if we could pull it up in front of us to discuss, please.
Do you have your balance sheet?
I do not have it in front of me right now, sir.
Okay, I don't have it in front of me at the moment either.
And I hate to ask you, but would you please repeat your question now that I can see what you're talking to?
Yeah, it's not a problem. No.
Thank you.
Long-term debt declined from 19.7 million to 5.8 million between 2020 and 2024. The biggest change occurred between 2021 and 2022, when it fell from 15.4 to 11.7. And I think that that's impressive. I'm wondering how you did it.
I will have to get back to you, as my tenure here at CVMC only started in 2021, and I do not want to give you a false information. So I can
Makes
follow
sense.
up with you for that if you wouldn't mind. Thank you.
I don't mind at all. That makes sense. If we can keep documents up, if we could turn to the income statement, there's a substantial variance often exists between budgeted and actual values for a given year. You addressed some of that in the presentation today. But for example, with the income statement, bad debt budgeted in 2024 was 6.4 million, and it's now projected to be 9 million. And I'm wondering what happened to throw off a budget item like that by nearly a third.
Again, I will have to look at the details to drive between, to do a crosswalk for you. I don't have that right in front of me, Member Walsh.
I'm trying to understand with that as an example, in the budget from 2020 to 2024, there's often substantial variation for an item from what is budgeted to what actually happened. And it's important for me to try to understand that when I'm looking at a budget for 2025, how much can I trust that that budget is what is going to materialize? Some of the hospitals that we regulate, their variance is quite tight and small. Others, it's quite large. And when there's a large amount of variation from budget to actual, it makes it difficult to make decisions on the budget that's in front of us. In the 2020 budget, your operating revenue had 16.2 million listed as an other for operating revenue. The actual was 41 million. Your operating revenue includes a budget of 18 million for that same item in 2025. What is other in the context of operating revenue, and what causes so much variance at times?
Again, I was not here in 2020, so I cannot answer that, but I would be happy to crosswalk those years for you in a follow-up document. I can
Okay.
tell you what's in the other for 2025, but I cannot guarantee that the other is the same crosswalk back to 2020.
Great. I'd be happy to hear what's in other for operating revenue in 2025.
Okay, we have employee self-insurance plans for 8.2 million. We have small and non-contracted commercials, so those are individuals that we don't have contracts with, for about 9.7. We have public agency for about 5.8. Workers' compensation, 4.6. Self-pay, which does not have any insurance tied to it, is 5.4. And then we have a small dollar amount that is about 1.9. And then in the same other category, we do have favorable adjustments or unfavorable adjustments for payer denials, such as timely filing, prior authorization, and or medical necessity.
Okay.
Actually, if I can just jump in, I think actually, Member Walsh, you're referring to, I think, something that's, Jay, I don't know if you can scroll down just a little bit further on the profit and loss statement there. Are you asking about that line on the bottom there? We just want to make sure we're answering the one that says non-operating revenue.
No, I'm asking about operating revenue. And the image is very small. I can't see it, but it's the operating revenue. And in 2020 budget, it was listed as 16.2 million. And so I think that's higher up on the page that's on the screen.
Okay.
And then the actual became 41 million.
Member Walsh, I'm having a hard time seeing it as well. Can we pull that up so we can see what line you're looking at? Because we might be thinking, given the year you're referring to, that we might be it might be one-time COVID funds that we experienced, but we'd need to check that.
That does make
It-
sense. And the items that were listed also make sense in that bucket.
If I could interrupt for just a moment, if we're going to be asking questions about detailed dollar numbers from years 2 or 3 or 4 years ago, I think it's really important for the purposes of clarity of record that we identify the document that it's in and put it up on the screen, because I think the exchange that we just heard will be really hard for anybody to decipher after the fact.
Well, this is the balance sheet and the income statement that you all submitted to us.
I'm asking that we pull it up on the screen and
It's there.
identify it so that everybody who reviewed the hundreds of pages of documents that were submitted is talking about the same thing. I think that will serve everybody, the Green Mountain Care Board, the hospitals, and the public better.
Well, I agree. There was an enormous amount of.
Let me interrupt for a second. I have a suggestion that might help. I think some of these questions are more directional and sort of what was going on generally that assisted with this issue or that issue, such as like the debt going down or those kinds of things. So I don't know that for a general question we necessarily need the document. However, I think the point is fair. And maybe what we can do is we can try to do the questions or the answers in that sense. And if you're unable to give sort of, hey, we worked on X or we worked on Y or we saw this during a break, we can try and get the specific documents. Because I think, Mr. Miller's point's fair. Why don't we try that and see how that works? And if not, we can get the exhibits during a break.
Sure. If I could, I think the point's fair. There's a tremendous amount of documents. And this is the document. But those are all the questions. I think they were answered. And those are all the questions about those documents. So if it's all right, I'd move on. So I did review the documents that were submitted. And I listened to Wednesday's presentation and today's presentation about administrative overhead and the different ways of calculating it. Nashby's version versus your version. And other than slide 29 in your presentation, I'm wondering where in your financial documents I would see a reduction in expenses that could be attributed to shared savings because of your affiliation with UVMMC.
Rick, if you don't mind, I'd like to pull you into this conversation because this is a network conversation in question.
Yeah, I think
I'm sorry, let me interrupt just one more time because I think I made a mistake earlier. I don't think I asked for the names of everyone sworn in, and just for the record, I want to make sure we know who's sworn in. So can you say the names of the people that were sworn in, just so we can make sure everyone is?
Sonny Epen,
Rick Vincent.
Mark
Teresa
Stanislaus.
Vaughn.
Mark Stanislaus.
Brad Crump.
Kelly Chapney.
Anna and Kim, I think were also sworn in, and I don't know if you heard Dr. Fama was also sworn in. I know they've already spoken.
Okay, so those five, Ms. Noonan, Ms. Patna, and Ms. Fama, Dr. Fama, correct? So 8?
Correct.
Okay, great. So, I'm sorry about that. That's my fault. I should have done that earlier. So thanks. And I didn't mean to interrupt. Mr. Vincent, please go ahead.
So Member Walsh, based on the profit and loss statement that is up on the screen, which is from the adaptive system, so the system that your Green Mountain Care Board staff uses, that detail isn't there, but we can show you over time where embedded in these lines where the shared service cost is and where it's been trending and what the variances have been over time.
Great, that'd be helpful. It's on a number of occasions, it's been offered up as an explanation for the apparent high administrative overhead, that it's because there's a mothership, if you will, or a primary site, and that's where the overhead would be. But then I would expect to see savings at the affiliates, and I'm trying to find evidence of that savings. So I'd like to switch to the RAND data if we could. That was discussed quite a bit on Wednesday. At CVMC, the total facility price is 282% of Medicare. The state average is 298, national average 269. The largest hospital in the state drives that average up to 298. But hospitals like CVMC that do not have a parent affiliation have total facility prices that are in the 150 to 175% of Medicare range. How do you interpret these data? What's more expensive at CVMC?
Rick, do you want to respond to that?
Yeah, actually, again, if we could just pull that up, I just want to make sure that we're responding to the question appropriately. Is there a chart, Member Walsh, or that you're looking at there?
No, not at the moment. These are my notes, and this is the same as the discussion on Wednesday.
So I can share a little bit about the discussion on what we've learned in looking at the RAND data more generally. I won't be able to necessarily provide any comment specific to CVMC. So in terms of inpatient, as we said, it looks like inpatient on. Actually, I think we do have a slide, Member Walsh, that we can reference. If you just give me a moment. Jay, I don't know if you have UVM Medical Center's presentation by any chance. I can give you the slide number if you do have it. I'm trying to find it here.
That's all I need. That's all I need, Rick, just the slide number.
Okay, if you could keep scrolling, go down, down. Keep going. Okay, right there. Thanks. Yeah, now go to the previous slide. So will this help, Member Walsh, to answer this question? Because we do have CVMC data on this slide here.
Sure. And I'm wondering, the question is that prices at CVMC seem higher than similar unaffiliated hospitals. And I'm wondering why that might be.
So I don't know if we can answer that question here, but in terms of the data that we do have, so relative price compared to the acute care median that was in the RAND study, obviously that's below the median and the average. Standardized price is below for CVMC as well. And then the actual price is a little bit above for both the median and the average. If you flip to the next page, where we looked at RAND outpatient, so CVMC is towards the bottom of that chart there. So in terms of the other Vermont hospitals, hopefully that gives you a sense on where they fall compared to the other hospitals. And so it's not, they're actually below some of the hospitals that are not affiliated with other systems. So I don't know if that helps provide a little bit better context.
I see that for the commercial outpatient. I'm wondering about total facility price, but let's move on to something that doesn't. I don't think this next question requires. It's built off a question that Member Holmes asked on Wednesday, where she was talking about the break-even price from the NASHB data, and with that break-even price, a lower break-even price signals higher productivity, higher efficiency. In the RAND data, the gap between the total facility price and the break-even is also considered productivity and efficiency, an assessment of that. So I'm just wondering at CVMC how you monitor productivity and efficiency, and what your sense of your organization's productivity and efficiency is today.
So I'm wondering, Member Walsh, if you're talking about provider productivity, if Brad Crump might want to speak to that in general terms.
Good morning, everybody. Morning. So as Dr. Fama mentioned earlier, we have, really a national conversation about looking at provider productivity differently. And Member Holmes, I do want to just admit to you, when you asked this question the other day, I was a little kind of emotionally taken aback at your personal story, and I didn't really have a good opportunity to explain the larger context. So I'm happy Teresa did this morning. So specific to CVMC, we have a variety of initiatives going forward to improve the historical definition of productivity. As the folks know, when we looked at primary care, when we switched to risk-adjusted panel sizes, the intent under the belly of that actually is to increase the traditional sense of provider productivity. The challenge, though, of course, is kind of those downward pressures on the system. And I suspect, folks who talk to providers across the state recognize those downward pressures are very real, right? The example of the electronic health record, hence our investment in tools like ambient AI, because we believe strongly as a system that we have really an obligation to the providers to remove those barriers, to move those things forward. Then, of course, you get into the technologies that we're looking to roll out really as quickly as possible. Things like FastPass and ticket scheduling. Those will improve that historical number just by using that technology. So that's my sense. If I didn't answer the question directly enough, Member Walsh, feel free to ask it again.
No, I think I'm interested in how at CVMC, you're assessing productivity and efficiency. And similar to Member Holmes' questions on Wednesday, if you have goals regarding productivity and efficiency for 2025.
Yeah, absolutely. So similar answer in that sense. So let me start there. So we build the budget really looking at what we rationally think we can achieve. And I'm sure the folks have seen in the budget submission, that CVMC has increased the aggregate productivity. I think it's by roughly 10%. But again, that historical measurement, kind of pre-digital world of work RVUs. But of course, that doesn't really get to your question around efficiency, which I think was Member Holmes' question around work RVUs per provider, right? That's really kind of the crux of it. So that's really where we get into, those things like FastPass and ticket scheduling. I don't personally believe, and I promise I'll answer the question directly in one sec. I don't think it's a coincidence that in America, the AI technology has the quickest uptake in the healthcare industry. It's kind of insane to me that in American healthcare, we would take our top, most skilled talent and ask them to do remedial administrative tasks all day, or maybe repetitive would be a better way to say it. And so as we look at AI, things like Ambient, there's a lot of AI coming in terms of the MyChart tools. I think that's where those investments have to go to free up that time. To Dr. Fama's point, we have really good, it's called signal data in Epic. It's pajama time, right? So it is challenging when we hear things, when providers hear things that sound like see more patients, and those same providers are doing documentation after they put their kids to bed, right? So that's the dilemma. To answer the question specific to primary care, our target as we look to the high value care staffing is not only to close care gaps, but it also is to get to that median productivity. And then specific to specialty care, the way we're working through this is a little bit more, I would argue, pragmatic, and really going through provider by provider, clinic by clinic, and identifying opportunities for improvement, right? Really saying to ourselves that even though, the complexity of that traditional measurement isn't good, the access situation is a crisis. So that's not good enough either. So kind of finding that balance between the two. So for example, in neurology, we just hired an EEG tech. For cardiology and endocrinology, we're looking at expanding the space. Both of those clinics are bottlenecked. So this is kind of the active work we do on a weekly basis, and literally have a grid kind of per clinic of how we're doing it. I think the bigger challenge is, and I hope everyone can agree with this, is I don't want to change the topic from providers, the system should be more efficient. But I think we can all agree the best way to improve access is we need more clinicians. And that's really where we've made some investments. I think Sunny mentioned this the other day about being much, much more proactive in our provider recruitment. We're seeing some gains. You see it in some of the budget, but I don't want to pretend it's as close to what we need it to be.
Member Walsh, I'd like to just bring up other perspectives as well. So Brad, thank you for speaking to the provider side of it, but efficiency is something that we need to look at and continue to learn about in all aspects of our health system here. So one example of that is our physical therapy rehab services. We utilize an outside benchmarking tool to look at our productivity as far as physical therapists, et cetera. On the nursing side, we use nursing hours per patient day. And so we look at the number of patients we have, and then we look at that as compared to our staffing. We have a lot of turnover at CVMC on a daily basis. Our census can shift from having a high of 80 patients down to 40 patients within 24 hours. And that's what we're trying to do with that is really focus on throughput and getting patients out of the acute care setting when they're ready for that to be discharged home. So we do have other measures of productivity across the system that I wanted to bring into the conversation. So I hope that gives you a sense of a few other ways in which we look at quote unquote productivity across the acute care setting as well.
I appreciate that. And I appreciate, I think it was Brad with the context. I think it's difficult. Member Holmes, Jess's story at the end of her questioning about her difficulty getting through was, I think, something that is a caution to me about relying on technology to enhance productivity and efficiency, because electronic medical records were supposed to do that. They were supposed to free up providers to be able to take more care of patients. But it has led to, I think Dr. Fama was saying 200% growth in essentially emails to patients that need to be answered. And oftentimes those may save an office visit, but also they may have been able to be handled by support staff. So it's a difficult concept or difficult topic, sorry. And it's what I did hear was that there's a lot going on. There's a lot of thinking about it. What I didn't hear were specific goals and specific ambitions for 2025 to improve the productivity of the people that you have. And so I'd be interested in learning more about that when we meet again next year. I'd like to turn to quality if we could. The readmission rate and safety measures at CVMC are both below national averages, and the Medicare star rating has declined from 5 to 3. And I'm wondering what is being done at CVMC to address the decline in quality.
So first, just want to mention that the CMS star rating, some of the data sets within that rating are lagged in some of those domains. So some of the data is not as contemporary as we would like. So what we do in that space, Member Walsh, is we have consistently looked at identified opportunities for improvement as it relates to quality indicators. So we have dashboards that we use across our system that are slightly different depending on the population or the services we're providing. And we're constantly tracking those outcome measures, which are more contemporary to potential performance. So it is a continuous process of improvement, and a lot of different work is going on to try to reduce any of changes in those data that we've experienced and that are being seen in those star changes. So just know that there's a lot of work to move those measures in the right direction. On our long-term care side, we have just back up to 4 stars as an example. So that notion of continuous performance improvement is a matter of reviewing the data, understanding the drivers of that performance, and then putting strategies in place to improve that performance, and it's continuous. So know that our goal is to be the highest star rating as possible for CMS. We also use other data sets to compare our performance that is more risk adjusted, and that gives us a better lever in some cases of where we have opportunities for improvement and what we can do to improve the care we're providing. But know that that's always our goal, is to provide the highest quality care possible.
Yeah, I believe that fully, that is what everybody's trying to do. So you have internal dating with more internal data monitoring with more timely data. Did those allow you to foresee the decline in star rating? Were you expecting that decline?
We had some concerns in a few areas, and again, as soon as we're tracking these continuously, when we see that kind of shift, and if the trend is sustained, we move in the direction of what. First of all, analyzing the data and then understanding what if any variances are to the standard of care, or levers we can pull to improve those data set. The other thing that's a challenge for us and likely other organizations of similar size is we have small ends for some of our data sets, which can impact the data as well. But that's not just felt here, it's felt by similar sized organizations with small ends in some of these data categories.
Okay, thank you. Was someone else? Okay. That helps give me a sense of what's happening at CVMC. I'd like to turn back to your narrative. You described spending $320,000 to update endoscopy services, and also reported updating STERIS reprocessing. There was discussion about Mako robots, and you described those in your presentation today. But I'm wondering if you could help me understand what STERIS reprocessing is and how much was spent to update it.
So the STERIS system is a state-of-the-art system for reprocessing scopes that are proximal to the site of care. So that system was moved from our central sterile reprocessing area to being within the suite where we do endoscopies. And the major driver there was its relevance to infection prevention because of the level of sterilization that occurs with that system. And then the proximity to the actual suite reduces turnover time for the use of that instrumentation. So the investment there is moving the equipment that we need to provide that service closer to the site of care and optimizing the sterility of the tools we use and the instrumentation we use in that space. And then we spent approximately $500,000 on the total project, which includes equipment, some construction, et cetera.
Okay, thank you. And I appreciated the explanation about the Mako robots. And you can get back to us with this if you don't have it, but how much was spent to update the robots?
I would have to, as you mentioned, go back and look at that specifically.
That's fine.
So we can get back to you on that.
Great, absolutely fine. Similarly, could you clarify what a linear accelerator does?
So the linear accelerator allows for clearer imaging of the site that requires the cancer treatment. And that level of precision allows for more precise treatment. It's a radiation treatment, and updating those linear accelerators will allow for better precision of visualizing the area that requires that treatment, in addition to potentially requiring fewer treatments. And in total, it's a more efficient process, less impact on the patient.
Right, I'd be interested to know how much was spent to update that at CVMC. And I'm also interested in how often it's used at CVMC.
So just to clarify your first question, that we've have a CON submission on that now. And so that's in process. And around the actual volumes we do there, we can certainly get back to you, Member Walsh, with that information.
Okay. Your narrative described substantial growth in the utilization of diagnostic imaging studies. CT scans, for example, were up 18%, PET scans up 27%, MRIs up 14%. Would you please comment on the alignment between the updates that we've been discussing and the increase in imaging services, the alignment with the community needs that you identified with your community, with risk behaviors, mental health care, substance use disorder? care. How do you see the alignment between the places that are growing and where you're investing and your community's needs?
Yeah. So fortunately or unfortunately, there's increased needs in the community that aren't impacted by acute care services. So those are some of the domains that you're referring to. We're working with our partners through Thrive to try to impact on that, specifically in the substance use area, et cetera. And your second part of your question, could you repeat that, Member Walsh?
The alignment or lack of alignment between the growth that you're describing and the investments that you're describing, with what the community has told you it needs.
So our community needs both. So what we looked at to project and invest in some of the programs that we have on the acute care side, meaning radiological studies, et cetera, are based on the demand of that aging population and the population as a whole. So we have projected and in some cases already increasing the volume. We're seeing increased volume in CT, MRI, et cetera. That is a need for the community based on their diagnoses, et cetera. On the community health needs assessment side, some of the areas that were identified for focus, substance use, et cetera, we have, I think, a very robust substance use program here that preceded my tenure and was led by a number of our clinicians in our emergency department that have impacted on substance use. But substance use in Central Vermont in particular, in addition to the state of Vermont, is on the uptick. And so that's what's driven the work we've done to try to impact on that with that, bringing that coalition together. They meet monthly. There's over 20 agencies that come together to talk about how we can pool our resources and our expertise to try to make meaningful change in that. And the recent grant we received, which will be over 5 years, will help us. And we hope in taking that family lens approach to substance use in the youth sector.
Okay, I appreciate that response. My final topic, and this occurred this was in your narrative, also in UVMMCs and all and Porter as well. There was a lot of discussion about the pricing dynamic called cost shifting here during Wednesday's evening or Wednesday's hearing. So I want to return to one portion of it because I want to make sure that I understand your view. In paragraph, I want to be specific about this or move it out. So just a second. In your communication with us, you've said that you understand that subject matter experts have concluded hospitals in consolidated markets use their market power to negotiate higher commercial rates. You say that this may be happening in some parts of the country, but the dynamic is not happening in Vermont. And it's not happening because of the board's insurance rate setting authority. And so I asked this on Wednesday. I want to ask it again to make sure that I understand. Have your prior budget submissions to the board included estimates of the amount needed to cover underpayments from government payers?
Member Walsh, can you just refer to give us like the page? You're talking about our narrative right now?
I can actually answer. I can answer
Okay.
that.
Thanks, Rick.
Without having it pulled up. Yes, Member Walsh. We've done that calculation the same way for 7 or 8 years for UVM Medical Center Porter and CMVC.
And has the board approved the majority of the increase that you've requested?
In terms of the majority, we'd have to go back and look through the years. There hasn't been I don't believe any year where it was approved as requested. They've been reduced, some years more, some years less, but we can go back in time and provide you with that data for CVMC.
Has the board ever specifically removed a portion of the amount you've calculated as needed to be shifted?
In so much as if the rate request that we put into the budget was reduced, that would be the equivalent of eliminating a piece of what we needed to cover.
If the calculation presented to us said that 50 million was needed to cover underpayments from Medicare and Medicaid, has the board ever denied that 50 million or reduced any part of it?
So you're using that just as an example of in a given year, if we said we had $50 million worth of cost inflation and Medicare was covering 10 and Medicaid was covering 5, and what was left over is our commercial rate increase. Are you asking, has the board ever reduced that amount?
Yes.
Yes, when we submit our commercial rate increase, if it's reduced, then we're not covering that 50 million, that full amount.
And has the board ever reduced has the board approved the majority of the increase you've requested?
Again, we can go back through the years and take a look at what the approvals have been over time.
Okay. So I've only been here 3 years, but I don't recall a time when we've reduced the request by more than 50%. I could be wrong, so we can go back and look as well. I've tried to ask the questions today and Wednesday about cost shifting because I think they're important. I'm not a subject matter expert on the cost shift or price discrimination or cross subsidization or any pricing dynamic. And I think from the answers to the questions the last couple of days, it appears that you all are experts on your facility, but not the concepts in general. But you've portrayed your understanding of the cost shift as central to your budgeting process. And it's a well-known leadership principle that I would defer to experts, that if you're not a subject matter expert, you defer to others with expertise. And that's why we at the board have consulted with national experts, asked them to present to us and present publicly. And we've worked to continue to understand RAND and NASHB and others that have incorporated the most recent evidence on the pricing dynamic that you call the cost shift. We expect clinicians to practice evidence-based medicine. That is, if the evidence changes, we, patients, expect that clinicians will adapt and follow evidence. And mentioned at the top, Dr. Fama noted for the need that we all pay attention to understanding measures when evidence changes and needing to adapt. I expect us as regulators to be evidence-based. And I think Vermonters should expect that we have evidence-based administration, evidence-based legislation. And because the evidence is so strongly contrary to what you present as cost shifting, I think we, the GMCB, can't continue to act as if your use of the term is evidence-based and shared by experts. It's just not. Vermont's hospital prices have risen faster than anywhere else in the nation, and the self-generated gap between the government payments and those prices that you're setting have it leads you all to set still higher prices because that gap is widening. And that misunderstanding of the cost shift has been a self-reinforcing accelerant to Vermont's rising healthcare prices. And these rising prices have real harm to our communities. In June 2024, the National Bureau of Economic Research released a paper by Zach Cooper, as well as others, titled "Who Pays for Rising Healthcare Prices?" The authors showed that every 1% increase in a hospital, not a referral region, but every 1% increase in commercial price is associated with an increase in unemployment insurance payments in that region served by the hospital by 2.5% because of local business closures and reductions in workforce, and a 2.7% increase in deaths and suicides by suicide and overdose in the region served by those hospitals. So these rising prices, it's an affordability crisis, not just pocketbook, but real health harms. The qualitative and quantitative data you've submitted, which we use to review budgets, show that the community served by CVMC is increasing, is going into debt in higher than your expectations. The budget to actual is off each year. And from the discussion today, you're prioritizing expensive services that aren't aligned well with identified community needs. And you're requesting a commercial price increase that's nearly 2 times our guidance. And so as our perspective as the board, we have to consider the harm that that does. And so I appreciate you taking the time to answer questions and think through this with me. I apologize for any confusion about which income statement or balance sheet. There's an awful lot of documents being passed back and forth. But I appreciate your time and thank you for answering questions today. And with that, I'll turn it back to you, Chair.
Thank you. So we've been going about an hour and a half. So why don't we take a little break? I think we're doing well on time. So why don't we take, let's take 14 minutes, if you don't mind. I want to take a look at something. So we'll come back at 10:40 and we'll go off the record. Thank you. Ms. Noonan, do you have everyone back on your side?
I believe we do.
Great. Okay, go back on the record and resume with board member questions. And I'll turn it to Member Holmes.
Okay, great. Thank you so much. Thanks for the presentation this morning. I'm going to start actually with a question that's in the CVMC narrative, but it was actually in all 3 UVM Health Network submissions. And I meant to actually ask on Wednesday, but it fell off my list. So maybe we can just talk about what it means for CVMC today. And this is in the area around the question around zero-based budgeting. It says in the narrative at UVM Health Network, our budgets are basically not developed using a zero-based budget because it is an enormous undertaking. And then the narratives inclusive of CVMCs say, if we were to truly conform, it would require the removal of the staffing guidelines that have been agreed to in labor contracts. So I'm wondering if we can hear a little bit more about what that means for CVMC. If you were to do a zero-based budget, why would that require the removal of staffing guidelines already agreed to?
So for CVMC, we have currently two bargaining units, a RN and a technical professional. So those contracts are for us negotiated on April 19th, and so they're fixed for 3 years. And so we would have to build those contracts into the zero-based budget. I think the broader challenge with zero-based budgeting for organizations of our complexity is it takes tremendous manpower to go to zero and build that up. So what we do instead is validate the current budgets, looking at volumes, looking at changes that we've had in our system here at CVMC as an example, and we make them contemporary to what we are experiencing today and what we're projecting to experience in the next fiscal year.
Okay. Okay. You have described some of the workforce challenges that you face, and some of that bargaining, I'm sure, contributes to your ability to recruit and the wage increases that you've agreed to. I'm wondering if you can just, I think I know the answer to this from the other hearings, but or the other hearing and potentially past hearings, but what percentile do you benchmark clinical salaries to nationally? What percentile?
So it depends on the job category. So what we try to do is we use external vendors to supply benchmarks for varying categories of employees here. And we look at the median of those salaries. And for some job categories, it may be local or regional. And for others, like providers, both physicians and APPs, obviously they're national.
Okay. And you target the median, so the 50th percentile for clinical MDs and nurses.
We do, but I think as was shared at Wednesday's hearing, the median is becoming more and more challenging in successfully recruiting applicants to Vermont. And part of that challenge is the cost of living piece, housing, daycare, other things that impact people's ability to move to the state and live here.
Okay. I think I heard on Wednesday, 50th to 65th percentile is where you've been landing, at least. Is that right? For the UVM, it was because of the challenges in recruitment. So sometimes had to go above the median. Is that right?
Correct.
Chair Foster, I see Mr. Crump's hands up. Is that okay if he adds in here?
Definitely. Yeah, please.
Great. Sorry, I don't always know the rules. Thanks. Yeah, just to clarify on the physician side. So for CVMC, we do target the 65th percentile of salary for physicians, but that dollar amount is prorated to the quote clinical productivity, meaning work RVUs.
So can you tell me a bit about that?
Yeah, absolutely. So the compensation plan for physicians, what we take is the benchmark we use is Sullivan-Cotter national benchmark. And for the salary, we have what we internally refer to as market adjustments. So the salary benchmark for CVMC is 65th percentile, but then we look at the 50th percentile for the work RVU production. And if you can imagine dividing those two numbers together, that gives you $1 per work RVU value multiplied by the work RVUs that the physician produces. So I just want to highlight it is prorated to the production.
Okay, so it sounds like you're targeting for expected productivity around the 50th percentile?
From a
That's what
benchmark
you're-
perspective.
From a
yeah.
benchmark perspective, yeah. Okay. Okay. I may come around to ask a little bit more about that in a bit, but let me just ask about, I'll ask these questions then about productivity. So productivity, I hear the concerns about work RVUs to assess productivity, and I want to acknowledge that I address that all providers across the country are messaging patients and taking advantage of e-consults likely, and it's important work that is not captured, by these work RVUs. So I look forward to learning more about better ways to, capture and nationally benchmark the important work that our providers, are doing for our patients. But at this point, it seems like work RVUs is the best comparator. Apples to apples comparisons of relative productivity. So I did notice there in the narrative that CVMC is budgeting clinical productivity at the 21st percentile for PCPs. And then for APPs, it's budgeted at the 45th percentile. So I'm wondering if you can talk a little bit about that, the difference between those two, and then in terms of the budgeting, the expectations there in the budget, and then also from what you just described as a benchmarked expectation of the 50th percentile for work RVUs, and how that all works with the compensation. So maybe we can just talk about that for a second.
Yeah, absolutely. So starting with primary care, same thing I said when we talked to Member Walsh a minute ago. So for example, with the high value care work we're doing, just to make this really pragmatic. So for example, in Berlin right now, I'm just reading some numbers to you. We have work RVUs per clinical FTE for physicians of 4,478. Our internal target, once we have the high value care staffing model there, is 5,747, and that is the median. So I think that's the question. Specific to APPs, they have different benchmarks, recognizing they're going to see different acuity. So for example, that same situation in Berlin right now is 3,482 work RVUs per CFTE for APPs, but the median is 3,875. So just to repeat that, there's a 2,000 work RVU differential in those benchmarks between the APPs and the physicians.
Got it. Okay, and you said something about, I think you described that, you're targeting the 50th percentile, right? Can you just repeat that, what you just said? I'm just trying to understand the 21st percentile is what's budgeted.
Mm-hmm.
But the target sounds like what you had just described was at the median.
Yeah, absolutely. So the hypothesis is we can staff up to what we call our high value care staffing model. Recognition of exactly what you've been stating, right? The current state needs improvement, and then through that staffing model is to move people towards the median.
Okay. So is it possible then that you've under budgeted for primary care if it's currently budgeted for fiscal year 25 at the 21st percentile for PCPs?
I would say it's always a timing issue, right? So like the example I just gave you, member homes, those details have actually been worked out roughly around the time we submitted, maybe a little after. We're actively working on this on the ground. So even how far we've gone from planning to implementation between the time we submit a budget to even today, let alone 6 months from now, it does move pretty quick.
Okay. I'm just trying to understand how it might affect actual NPR for next year if it's what you're describing. And then when I do look at, the other numbers in the specialty, actually, if you just look across the board, it does strike you that CVMC as measured by this measure does seem low compared to other hospitals in the state, having seen now all the other hospitals, work RVUs per clinical FTE, 50 out of the 60 areas are below that median. 20 of them or so are below the 10th percentile. So part of me, I'm curious about the statement that you made earlier about it. We can all agree that everybody, that we need to hire more clinicians. Can you talk a little bit about that, given what we're seeing here in some of the specialty areas, that the answer is at hiring more clinicians?
Yeah, absolutely. So what I was trying to say, I don't know if I said it that clearly, was I hope we can all agree that hiring more clinicians is a direct line to improving access. To your point, around, because I think we've been mixing and matching through this conversation for productivity and efficiency, right? Because those are obviously intertwined, but not the same. And that's really when you think about increasing that productivity, that's the discussion we've been having about, rolling out ambient AI, the FastPass, the ticket scheduling to increase that provider utilization. So I think that the combination of things we are working towards is really a partnership, I would say, between what should a system like this be doing for its employees and for its providers, right? Taking these tasks and these downward pressures out of their time, because time of providers is, in my opinion, one of the biggest, if not the biggest, commodities in healthcare. And so that's what the system owes the providers. And to your point, in return, we're partnering specific to CVMC with all of the providers per clinic to really understand from their perspective what are the things they need or what are the things they can be doing differently. So it has to be the combination of the two, which is where I think I reference kind of that much more tactical, hand-in-hand work to, one provider, one clinic at a time to increase that productivity.
Okay. Yeah. Because I think the goal should not be to increase provider burnout, right? But is to try and find efficient ways to utilize provider time to increase throughput, right? And increase these productivity numbers so that they're closer to the national average median or national median without burnout.
Yeah. And I'm sorry.
Go ahead.
I agree. I'll just agree with that because and I know you know this, we've talked about this before, like there's just such a give and take, right? Between asking people to do more and improving a system so it's easier and more quote efficient to work in. And to your point, like the ambient notes when we ran that pilot, self-reported providers are reporting a 54% decrease in burnout, right? And I think that's a good example of kind of that give and take that needs to happen.
Yeah, I can appreciate that, and I hope there's more of that rollout. Because just when I look at some of these, and you can tell that I've actually tried to dig into these to understand this, there are some specialty areas where the wait lists are long, right? You look at cardiology, you look at neurology. These are areas where patients really want to get in because they have a concern, their heart, their brain. And then there's, so there's a long wait and there's relatively low productivity. So my hope is that some of that mismatch can be resolved by some of these new initiatives that you're taking. I'm going to ask a question about an area that did strike me, a pair that struck me. Emergency medicine for CVMC, really highly productive relative to the other areas anyway, 65th percentile, but urgent care was at the 10th percentile. And so as I think about avoidable utilization in EDs, is there an opportunity here to lower costs, improve efficiencies by, working to have patients seen in urgent care, increase their productivity there, rather than putting pressure on the ED?
Yes. So, I mean, there's multiple opportunities, right? So one of the opportunities through the high value care work is really working with patients post-discharge to avoid readmissions or avoid going to the ED. I mean, you're absolutely right. Of course, we all recognize the challenge with EMTALA, which I think gets to your point of the broader systems position of how do you get patients to the right place in advance of them walking through that threshold.
Okay. My final just area on productivity is psychiatry was just another surprising area to me, particularly because there was some reference in the narrative to the inpatient psych unit. So according to the productivity, it was less than the 10th percentile for both general psych and inpatient psych. So one, I guess my question is, why would that clinical productivity measure be so low, given the mental health crises that we're in? And then secondly, it looked like from the narrative on page 37, CVMC's inpatient psych unit is now capped at 8 due to vacancies in provider staff. It's incurring a financial loss of $3.2 million. And and there's efforts being made to increase providers to get that census capacity of 14. So I'm trying to understand all of that.
So, Member Holmes, I can start there. So we did need to cap our inpatient census based on not having enough providers on site. And our providers here at CVMC cover our inpatient and any boarders we have in our ED. And that border number changes day to day, hour to hour. So they're moving between those two practice sites, if you will. So we did cap it based on that. Obviously, we're recruiting with our network colleagues to see if we can replace those psychiatrists. We're also using APPs in that space to try to balance the need to provide the care in those two settings. But that the driver of the limitation in providers has been a challenge.
Okay. Even though the productivity is at the 10th percentile.
My understanding is for psychiatry, productivity is inherently low, and it's a nature of the type of care that's being provided.
Okay.
I think we can
Just
come back
as-
to you with a good answer on that, a better answer from our psychiatrist, because I don't think we're completely giving you a good answer there, I feel like. I think part of it
That'd be
is,
helpful.
yeah,
Yeah.
part of it is
Okay, that'd be
the
great.
need
I'm
to
happy
take
to-
call. Yeah, the need to take call and how that gets covered. Part of it is exactly the movement back and forth that reduces the efficiency of what we can do. And then the other part, as I think Anna referred to, is the reality that the two psychiatrists that left, they left because they were getting paid to get paid more money to do the same work elsewhere. So it's like it's a real challenge for us there to hire that. But I think there is an explanation for that, the low P10 there and why that is as the nature of that. So let us come back to you with that one.
That's great. I'm happy to hear a more complete answer later. Let me just ask one final question around that. So it looked like at 8, capped at 8, it doesn't generate a margin there, or there's a financial loss of $3.2 million. How many beds are you budgeting for in fiscal year 25? And is there an expectation that it will at least break even that unit?
We've budgeted for 8 because recruiting for psychiatry is a challenge, not just here, but nationally. And also, it's important to note that when we ran 14 beds with a complement of staffing, we need both physicians and other staff. The psychiatry unit lost money at CVMC, and that's not unique to our organization. It's an issue across the U.S.
Okay. Yeah. Thank you. No, I appreciate that. I wasn't sure if getting to 14 was going to get you to a capacity that would allow you to break even.
No, unfortunately not.
Okay. I'm just going to switch gears. And I think this is, my last question here is really around the Woodridge Rehab and Nursing Facility. The extraordinary relief of $1.3 million. I'm wondering if you could just tell me what are the criteria to be granted that relief? What is that based on?
So there's a whole process for us to go through. So I'm going to defer to Kim, who is closer to the application for that, to give you some sense of the criteria.
Thank you.
Great.
Yes, member Holmes, actually, it is due to the cost, and it was running the cost with travelers. As you know, acute care travelers is really where we're struggling to get permanent staffing at our nursing home. So it does come at a higher cost. And so this is to help defer some of the cost that the state is helping us so we can keep additional beds open. We've been budgeting for an average daily census of 125 to help decompress and help take care of those long-term patient needs.
Okay.
We can also, Member Holmes, give you more detail, and if you want more detail about all the criteria, it's a pretty significant document to complete.
I was just trying general criteria. I was trying to figure
Yeah.
out what was unique this year. Is this going to be, has it just, it sounds like you're budgeting for it potentially next year as well. You're hopeful that it will still roll over. So I'm just trying to understand a little bit more about what qualifies for that.
In member homes, during the COVID years, we did get reimbursement or help from FEMA. Obviously, those dollars have dried up from federal resources. So the state has stepped in to help nursing homes, and we're not unique. Other nursing homes across the state have also been eligible to apply for and receive additional fundings. It does run on the state fiscal year though, which is July to June.
Got it. And so then with that relief, what is the net income expected for Woodridge for 24?
I don't have that.
If you
right
need
in
to
front of
follow
me,
up, that's
but I can
fine.
follow up with you. I'm sorry, member Holmes.
No,
Do you
That's
mean in
fine.
totality for Woodridge, or do you mean just with that program?
no, I guess I want to understand in totality for Woodridge. Yeah. And I guess my second question is there a subsidy that goes from CVMC, similar to what happens with Porter? Is there a subsidy that goes from CVMC to Woodridge to close, gaps?
Member
So
Holmes,
there-
yes, there is, but we would call that as an investment, not a subsidy, because without that investment, we would have patients that need that non-acute care patient stay in acute care patient bed. So it helps move the patient to the appropriate level of care. So we do have an investment that we do help out with our Woodridge space.
Great. So if you could just share, I mean, this can be a follow-up, but what was that investment in 24 projected to be, and what are you budgeting for in 25? And I recognize this is a follow-up question, trying to get a sense of the dollars flowing there. I think that is all I have. Thank you so much.
Great. Member Lunch?
Thank you. Thanks everyone for joining us. So I just have a few questions. In your answers to the staff questions, you included so it's staff question 3. It's on page 2 of your answers. Related to the primary care investments that you described in your narrative on pages 9 to 10, and you provided some data about what your primary care investments are. And I'm wondering if you can just talk a little bit about the impact of primary care on your budget generally. And it looked like there were some substantial increases in primary care FTEs in order to increase access. So if you could just speak to kind of the budget impacts on that, and yeah, I guess I'll stop there.
Kim, you want to take that one?
Actually, I do need Brad on this because this involves high value care budgeting and the needs for what our plan is to help improve and change the panel sizes. Brad?
Yeah, hi, everybody. So the way CVMC went about their budget for fiscal year 25 was to select 2 primary care sites and try to staff them up to what we're calling our high value care staffing ratio. So specific to Berlin, that's a request for 3 additional staff FTEs, and for Montpelier, 3 additional staff FTEs. The hypothesis, member Lunge, is with that additional staff, we can help those providers move their risk-adjusted panel sizes to ODE. We can help, as we discussed already, moving all of the providers to the median of the national benchmark of work RVUs, and increase provider utilization. Provider utilization is the metric, it's the retrospective metric of looking at really the amount of time a provider was scheduled to see patients compared to the amount of time they actually saw patients. And that's where we get into things like FastPass, where the early indicators were moving patients up on average about 45 days. So that's really the hypothesis. So we want to test that hypothesis. We have internal metrics also around wellness visits, depression screen ratings, closing care gaps, that sort of thing. And if we can move these metrics, if we can staff it, if we can move the metrics to the target, the goal then would be to upstaff the rest of those clinics as well. So in summary, what we did was we looked at our historical staffing compared it to the high value care staffing, and picked 2 clinics where we would staff up to test those targets.
Thank you. That's helpful to give me an understanding of the program. What I was interested in was also understanding the financial components in terms of impact on expense growth and revenue growth, specifically for primary care.
Absolutely. Kim, can you take that on the financial side?
I actually would have to defer back to you, Member Lund, with details. I don't have that right in front of me.
Totally
So-
fine. No worries.
Thank you.
Thank you. So just give me one moment. Question has been answered. It's handy going third. A lot of my questions have been answered, so just double check a couple more here. Could you remind me what your Medicare rate increase assumption is?
Can you clarify that, Member Lunch? What do you mean by that?
Sure. So as you've discussed, when you look at your commercial rate request, you subtract out your expected revenue increase from Medicare. And I was wondering if you can remind me what that increase is that you've calculated or expect.
I will have to pull that and give that back to you in a follow-up. I do not have that at my fingertips and I don't want to misquote a number.
Sure.
I can help to jump in if it's helpful,
Great.
Kim. So on
Thanks, Rick.
on slide 26, we don't have the percentage here, Member Lunge, but we can follow up with that. But the rate increase in terms of a dollar amount is 205,000 that we have in the budget.
Great. So I think the percentage would be helpful because certainly it's helpful for us to understand, what you're expecting in terms of how the standard Medicare rate increases will flow through. The percentage would be great. One second. So in looking at the adaptive income statement, I was noticing that your fiscal year budget to projected is actually a considerable percentage of your budget to budget NPR. But then when looking at your expenses, 24 budget to projected compared to 24 projected to budget, that same ratio doesn't flow through. So could you please talk a little bit about what efforts you have focused on expense reduction or expense management?
Member Lunch, can we have the income statement pulled up so everyone can refer to that file?
Sure, I can't do that, but I think somebody on your team pulled it up earlier. Right. Here we go. Thank you.
Thank you. I can start in the labor components. Do keep in mind, as Anna mentioned, we do have 2 new bargaining units that are part of the cost for labor now. It's our RN group as well as professional technical. We have finalized the first 3-year contract for this group of individuals. It makes up more than a third, a little less than a half of our employee population, and that contract cost is baked into this budget. That is what is more than likely driving the disproportionate share in our expenses, particularly in our labor component, as we also work to stay market competitive in our non-labor areas as well, or non-union areas as well.
Okay, thank you. That's helpful. But I'd also be interested in any cost savings efforts that you make to ensure that you had mentioned you examine your budget, you kick the tires on it. If you could speak to cost savings initiatives that you implement, that would be interesting.
Yes, one of the other areas that we are looking at is we are revising our benchmark data using the Centella system, again, that is available to us through our network partnership to update our hours per patient day formulas to make sure our staffing is correct and more aligned with our benchmarking to the Centella's individuals that participate. So that is one of the tools that we are looking at to increase our efficiencies. The other thing that we are also looking at is expenses, is that we're looking at, it's very similar to Six Sigma. We call it lean. We've put most of our leadership through our lean system for learning how do we adapt to improve efficiency and reduce waste in our system daily. And that is one of the measures that we started about a year ago. And we're really kicking off and having individuals use this tool throughout the house. The nice part is it starts right down at the frontline staff. So that's really where you can see the bigger changes because it's the frontline staff they're just doing the work.
Thank you. Okay, I think those were my major questions that weren't already asked. Thanks very much.
So Member Lunch, just to cut
Thank
down
you,
on
Member
the
Lunch.
follow-up, I did see we have a slide in there that does have the percentage, just so we can provide it
great.
to you now rather than in written follow-up. So on slide 21, it looks like the percentage for that amount was 1.1% for the Medicaid increase.
For Medicaid, you said?
For Medicaid, yes.
Okay. It was my understanding that DEVA had said they were not going to do any rate increases in Medicaid. So I'm confused by that, but I was actually asking about Medicare.
Oh, sorry.
That's okay.
So Medicare is 3%.
Got it. Okay, thank you.
And member lunch in the Medicaid space, I believe that part is related to the extraordinary fund request relief
Got
for
it.
Woodridge. So that does skew what it makes it look like Medicaid is getting a rate increase. It may not be.
Okay,
And that
thank you very
is
much.
a
That's very
budget risk
helpful.
for us. Yes, ma'am.
Yeah. Okay. Thank you, everyone.
Okay. I'll try and be fairly concise. On the shared services and the savings for CVMC on administrative costs by virtue of being part of the network, have you analyzed what those savings are?
We have, and as we shared earlier, we can provide that in follow-up over the number of years. Probably we've got 3 years of good data that we can share what those savings have been.
The provider productivity, how long has CVMC been reviewing provider productivity levels?
I can speak to that. In my tenure, we've been reviewing it every year and consistently throughout the year since I started, which was 2017.
And have the productivity levels increased since 2017? I'm speaking generally, obviously, and directionally, but have you seen those numbers move north in your time?
Generally, there has been improvement. I think the initiatives that we've launched that Dr. Sandoval spoke to yesterday, that Brad spoke to today, and Teresa has spoken to, are going to impact provider productivity by making the systems more efficient for providers to focus on direct patient care and supporting the provider in delivering that care by the EHR improvements we've done and the staffing models that we're trying to move to.
And do you retain and maintain the historical records on where the provider productivity levels were in prior years?
I would have to go back and look and see the degree of specificity that we have with that. I'm not sure, because we have shifted to the Epic platform. So previous to Epic, it was a little bit more of a manual process to calculate those productivity measures. With Epic now, since we've had that implemented, we've built that into dashboards that are reviewed by our medical group team on a regular basis.
Remind me when CVMC implemented Epic.
On the practice division side, it was 2019 into 2020, and on the acute care side, it was 2021.
Okay, so 2019 for the data relating to provider productivity?
Is when we implemented. It takes some time for those data to then translate into data that can be utilized for this type of purpose.
We'll have a follow-up. I'd love to see that over time from when it began, when you were tracking it in the same way. So maybe that's 2020 or 2021, but that'd be helpful to see how these have moved so far. Ms. Lajes, could you, I got some slides just for a couple things to kind of ease the questions. Ms. Lajes, could you pull those up if you have them?
Sorry, give me a second
You
to
can
put
just
in
go to slide
presentation mode.
2. Sure. Ms. Noonan, while she does that, does the CVMC board, do you report to the CVMC board the provider productivity information?
We don't specifically report those numbers. We're more in general terms.
All right, slide 4, please. So these are the audited financials from fiscal year 22-23. And this is a UVM-MC obligated group consolidating balance sheet. And at the bottom box with the arrow, there's a line that says due to related parties. Who at CVMC would be the most familiar with this document?
That would be me, sir.
Okay. So where the arrow is pointing is the current liabilities due to related party line for CVMC. Am I correct in reading that number at $32.2 million?
That is correct.
And that's an amount due to a party or entity related to CVMC?
That is correct.
And a current liability is something due and owed within a year?
That is by definition correct.
Okay. And do you know to whom this money is owed?
I do. The majority of it is UVMMC and UVMMC, UVMM Medical Group.
Medical group, okay. Is that, and what is it for?
That is the pass-through of salaries for physician providers that work in our clinics. All our physicians are employed by the UVM Medical Group.
I'm sorry, is the entirety of the $32 million owed for physician salaries to the medical group?
I would have to pull the details, but by and far, the large amount is the medical group.
Maybe this is for someone from the health network, but is the medical group, I mean, is it a subsidiary of the health network? Is that right?
Correct.
Thanks. And so the structure here is the health network has the medical group. The medical group compensates the physicians. The physicians, some of them work at CVMC. CVMC then owes salary and money to the medical group to pay for the physician services that it receives. Do I have that about right?
You do.
Okay. And the money that the medical group pays to the physicians, does the medical group hold that money that it pays out, or does it come from the health network?
It actually comes from the University of Vermont Medical Center.
Okay. Okay. You can go to the next slide. So this is the Central Vermont Medical Center consolidating balance sheet. And I pointed an arrow to the total current assets for September 30th, 2023 reporting. So this is the total assets that CVMC has as of this time. Is that correct? Total current assets.
At the time of the September 30th financial or balance sheet, that is correct.
A little over $58 million. Does CVMC actually pay back that $32 million we saw on the last slide? Does that get paid back?
Yes, it does, sir. We do have more dollars that flow between the two parties. That just happens to be the balance at that moment in time that has not been paid.
Okay. Does it get paid back in full?
That is the goal and the attempt.
And is there a timeline expectation as to when that $32 million due would be paid back?
In the due to, due froms between the entities, there is money that is continuously moving back and forth between the partners. And at this moment in time, at the September 30th, which is a moment in time for the balance sheet, that was what was open. There is additional dollars that flow that is not on the balance sheet that has already been paid. So it is a current liability, sir. It's not from years ago.
I see. Right. Okay. So as we go through a year, that 32 million, some of it might be paid down. There might be other money that's becomes due because you're getting others, like that can go up and down throughout the year, right?
Yes, sir.
Okay. And where does that balance stand today, if you know?
I do not have that right in front of me, but I can provide that in follow-up.
Do you know if it's larger or smaller than end of fiscal year 23 at 32 million?
Again, I will follow up with that, and so I make it an accurate statement to you.
Sure. But sitting here today, and that's totally fine. Like that's you're not gonna have every number we're ever gonna ask you about in your head. That's not gonna be possible. But do you have a sense of whether, just to your awareness of being familiar with this, do you know whether it's smaller or larger?
It will be smaller if I was to look at it today.
Okay, great. All right, thank you. And for total current assets as of today, do you just again directionally have a sense of whether the current assets are larger or smaller than the 58 million from September 2023?
Materially, I believe we are about the same, maybe a little bit more.
Okay, thank you. And these questions are just to make sure I understand the financial health. When I look at this, I want to make sure that you have an opportunity to make sure I'm understanding it correctly. So thank you. Next slide. Again, this one is from the Medical Center Obligated Group Consolidating Statement of Operations Fiscal Year End 23. Not the greatest resolution. I'll try and improve on that for next year. But there's a line that says transfer. I think it's transfer and other perhaps, or transfers anyway is the line. And this column has a negative of $1.2 million for CVMC. And my question is just what is a transfer and to whom is that going?
I am drawing a blank right now. Rick?
Yeah, I'm pretty sure we actually had this on the UVM Medical Center slide, Chair Foster, and I believe the number looks like it's related to CVMC's pension termination that we did together with Porter Medical Center. So we can follow up to validate, but that number looks like that's what that is.
A transfer potentially for pensions. That's what, okay. And I get that. Yeah, okay. All right, next slide. Quality, there was a financial penalty in fiscal year 24 from on Medicare payments. Had CVMC previously been penalized by Medicare for quality reasons?
So whenever we're not hitting the target, we don't achieve the full impact. So likely the answer there would be yes, but I'd have to go back and look.
Okay. Yeah, I'm trying to get a sense, like temporally over time, how CVMC's quality is doing. This would be a data point. So we'll ask that in follow up too. If you've previously been penalized and for what and to what degree. And then relatedly, do you have a sense of how CVMC's current quality reporting is on the metrics for which you were penalized in fiscal year 23?
So we track all of those measures internally and report them out. And as I mentioned earlier in our conversation today, we have performance improvement initiatives designed to try to improve our performance in each of those areas. But I would also tell you that there are a few areas where we will need to continue to put that kind of effort in. So it's a continuous improvement process.
Sure. Okay. I'll follow up for where you are currently on that. And what is the reporting? Can you give me a sense of what you call? I want to make sure we ask for it correctly. What do you call the reporting that you look at on quality? How would I ask for that correctly?
I think if you just correlated it to the Medicare program, hospital-acquired conditions piece, we would know which data to pull.
Are there other categories of quality that you and I guess regularly review and consider?
Absolutely. So outside of these programs, we have quality measures, again, based on data and our performance compared to other peers. So we're looking at a variety of clinical metrics. We also have process measures that look at care delivery. And as a network, we have operational key results that are tied to our strategic priorities that we track on a regular basis.
Okay. And do you report to your board on quality?
We do.
Okay.
Our board meets quarterly, and at each of those board meetings, they receive those dashboards, and there's discussion about performance in each of those indicators, in addition to the operational key result metrics that we track. So those are reported to our board quarterly. Absolutely.
Okay, great. Next slide. This is from the Leapfrog Hospital Safety Grades. Do you review the Leapfrog safety grades for CVMC?
We do not. We have not identified Leapfrog as a network as one of the benchmarks that we're comparing ourselves to, and that's been for quite some time. Most of the measures are self-reported, so we prefer to use some data sets that have risk adjustment models that allow us to really drive clinical improvement, and Leapfrog is limited in that way.
Did you review the spring 24 hospital Leapfrog grade and consider what they found?
We did not.
I may know the answer to this, but I'll ask anyway. Do you have any sense of why the Leapfrog grade, at least for CVMC, has been declining, from a B down to a C down to a D?
I would need to look at the data. The last time I spent any real time with Leapfrog was a number of years ago. And in that deep dive, we made the decision, not just here, but across the network at that time, not to use Leapfrog as a driver for our performance improvement activities. We use other benchmarking data.
Okay. And what's that benchmarking data that you use? What's that called?
The platform we use is Vizient.
Yeah. Right. And when did you start using Vizient?
At CVMC, we used Vizient. We've been using Vizient since I think approximately 2017. At UVMMC, it's been used for over 20 years.
Okay. Next slide. This is just a follow-up for the health network folks from the other day. I don't think we had the exact language on a question that member Holmes had asked. And so I pulled it up just to give it to you so you'd have it referenced handy. This is from the member Holmes asked about this. If you see here, I'll read it, quote, Vermont is the lowest cost provider of care for Medicare in the nation. And UVM Medical Center is in the second lowest 25% of academic medical centers nationwide, period, close quote. If you know sitting here, and you may not, but if you do, is that reference to the lowest cost medical center of academic medical centers based on Medicare?
Yeah, we'll have to get back to you, Chair Foster, just to make sure we know where that source came from I'm just not, I believe it's actually AAMC Coth, but we'll get back to you specifically.
Okay, yeah, that was one of our follow-ups, and I want to pull up. And then the next slide. I pulled it up from this morning, the same press release and clip, but that language was removed, it looked like. Do you know whether that language was removed from that press release?
Chair Foster, we'd have to go back and look at what you're referencing. I can't speak to that at this moment.
Okay, yeah, okay. This is from the website this morning. I just pulled a clip of it from this morning when I went to look at it, and it looks like it doesn't have a language. Maybe it was moved and I missed it, but it looks like that was removed. So I'm curious as to when it was removed and why. It just caught my eye and I wasn't really clear on why that would happen. Okay, I have no other questions. And we're going to do public comment for all the hospitals at the end of the day. So you're welcome to come back when you do public comment at the end, or you're welcome not to. So we can adjourn the CVMC hearing. We'll come back. What time are we coming back? We come back at 12:30 for the Porter hearing. And I had two other quick scheduling notes. One, Dr. Merman didn't participate in the CVMC hearing. He's recused himself, so he didn't participate today, and he won't participate in the voting on the CVMC budget. So I just wanted to flag that for the record. And then second, the public comment period on the hospitals, we've extended it till tomorrow night. I think there are folks that had comments that want to get them in, so we extended it till tomorrow evening. All right, thank you, everyone. Thank you very much, Ms. Noonan and your team for your presentation today.
Thank you for your time.
All right, we'll adjourn until 12:30.